Thank you everyone for having me here. I was a little late to the party due to some preoccupations back home, but I'm glad I'm part of this today. I am a GI medical oncologist at Fox Chase Cancer Center in Philadelphia, and I see neuroendocrine tumor patients for the most part. That's pretty much most of my practice. So today I'm going to talk about targeted treatments for neuroendocrine tumor. It's a very overlapping topic. A lot of things you may have heard before. You may be hearing as we move on, but we'll try to cover up. And as we said, there's so much information. Repetition is sometimes, I think, good. So I have my slides here. That's perfect. Right. If I can move them forward. Oh, here. Whoops. Should have just done that. Okay, let's try to do that. It's on. Maybe I can ask Mike in the back to just do it for me. That's right. Would that work?
Yeah, we're going to change the values. We'll change the values.
Sounds good. All right. So can you put the next slide on, Mike? Or maybe we'll just wait, I guess. But nonetheless, my first slide is actually mainly talking about, Dr. Muhammad just gave you a background on the history of serotonin and how that came about. And I am going to talk about, the history of personalization, how carcinoid started as a word in 1907 by a German scientist named Oberndorfer, and he basically found these cells that looked cancer-like but not really, and he named them carcinoid, which is just cancer-like. So he wasn't even sure if this is, but with time, how we have moved, and we've learned so much more about this disease. And one of the biggest things we've learned about this disease is how to target treatment. And the first receptor is the somatostatin receptor, as Dr. Muhammad just pointed out in his presentation. One of the most effective targets and more universally present target on these tumors is this receptor, and we have found a key to this lock. And using that, we've developed a ton of therapies, different kinds of them, as we will talk about. Somatostatin analogs like the lanreotide or octreotide or sandostatin or PRRT, and some newer drugs that are coming along. So this is just some objectives. We can move on. All right. Oh, perfect. So this is exactly that slide as I was just talking to you about. We can move on to the next slide. And this was my attempt at doing some memes here. So how it started and how it's going. So if you remember, as I told you, carcinoid, we just had one term before, and we have come a long way in personalizing this disease. And now we have, there's neuroendocrine tumors, there's neuroendocrine carcinomas, there's grade 1, grade 2, grade 3, there's mixed tumors, there's large cell, there's small cell. All of these different names are a step towards personalization of therapy, right? Not every patient that walks in the door is the same cancer. And we've learned a lot about this disease as time's moved on. This is a very simple schematic of what therapies are out there for this cancer at this time. As you can see here, if I can point to one, I'll just go here. There's PRRT, there's liver-directed treatments, there's Everolimus, there's Sutent or Sunitnip, there's chemotherapy, and we have actually made headway in making all of these personalized to different degrees. In general, for the well-differentiated tumors, our goals of treatment are twofold, right? We learned a lot about symptom management and the hormones it produces and the catastrophes that happen and the problems that the hormones produce. And Dr. Muhammad talked a lot about that, so maybe I'll wrap it up and not talk much about it. But other part is the tumor control, right? It is a cancer, it grows, it causes problems, and we need to control that too. So here it's not just one problem, we're dealing with two competing problems at the same time that we need to address. So this picture tells you a good way of what are the medical treatments that are out there for pancreatic neuroendocrine tumors. There's three big buckets. There's chemotherapy, which we typically traditionally call as non-targeted treatments, right? Because it's chemo, it goes and kills fast-dividing cells. Then there are somatostatin analogs, which again is the lock and key mechanism, which have octreotide, lanreotide, and Luthera. And then there are some newer targeted agents like Everolimus, Sunitnip. They're not new anymore, but relatively newer, I should say. When you move to the non-pancreatic GI neuroendocrine tumors, chemotherapy unfortunately just doesn't work for these cancers. So we just take that whole bucket away. We're left with the somatostatin analogs, and in terms of biologics, the only approved agent right now is Everolimus, which is an mTOR inhibitor, and we'll talk about it in a little while. So this is just I'm talking about targeted therapy, so I need a targeted therapy picture. So it's very confusing. You don't have to read what's in there. The only reason I put it there is to show you that these cancers have this special protein on their surface. This is the somatostatin receptor, right? It is basically that lock, and what happens is it's sort of downstream. As soon as it gets activated, it sends signal to the cancer and leads to three important things: hormone production, cell proliferation or growth, and division. So bad things happen if it gets activated. So if you block it, you won't have those things. Your hormone production goes down, the cells die, because they don't proliferate and they don't grow. So good things happen if you block it. So that's a very targeted way of treating this cancer. These drugs will only work if your tumor has this receptor on it, and so that's why it's very effective therapy and doesn't cause a lot of side effects. And these are the two big trials. There was first study, which is the PROMID trial, was for somatostatin analogs, sandostatin or octreotide, and the clarinet, which is the bottom study, was for lanreotide, which is a more recent one. And then more recently, we have another targeted therapy, which is Luthera, which is also based on the same receptor, the same lock and key mechanism, which is sort of I would probably say the base of how we treat these patients in a targeted fashion. A lot of my patients ask me whether they should go by, is sandostatin better than lanreotide or somatostatin? Is one better than the other? These are two drugs that are currently available. In general, I don't think, these were the two studies. And if we look at the data, what we know is that the sandostatin was tested in patients with intestinal, so small intestinal neuroendocrine tumors, in patients who some had symptoms, some didn't have symptoms. The lanreotide was tested in all patients who had pancreatic or GI neuroendocrine tumors, so it was tested in both, and it was tested in patients who did not have symptoms at baseline. So the study population in both these studies were slightly different, but at the end, these are similar drugs. They act on the same receptors. They work the similar way that in general, we tend to use them interchangeably. I personally prefer for pancreatic neuroendocrine tumors tend to use more of somatostatin, which is because that's where the data is, right? As I said, the data about sandostatin is only in small intestinal neuroendocrine tumor, the prospective one as we have it. Unfortunately, what usually dictates is insurances. Each insurance tells us that you have to use one drug or the other, so we use that. But just for you knowledge, in our medical community or scientific community, we don't think these drugs are much different one from the other. So don't be, why you're getting one or the other is mostly really a question of whether I take Advil or Motrin. This is another nice picture. I again put it to show you some targets, and it's not to educate you about how these things work. I just couldn't find a more simpler one, but I'm going to simplify it for you. So as you can see in this picture, this is a neuroendocrine tumor cell. This is the blood vessel, and these are all tumor cells, and this is a blood vessel cell. Okay. What it's showing is the main targets. This is the somatostatin receptor, so the lock and key mechanism receptor. This here is an mTOR pathway, so this is the mTOR signal, and there's a drug that can block this. And then in the blood vessels, these tumors produce special chemicals called the vascular endothelial growth factors, or basically think of it as signals for new blood vessels to grow into the cancer. And we have a drug that blocks that, Sunitnip. So in general, we have three different targets that are affected, and ultimately what they do is they prevent cell proliferation, metabolism, and decrease new blood vessel formation, lead to cell death, but all the good things that we need to prevent this cancer from growing. This is all we know so far. In terms of pancreatic net, the Sunitnip was a drug that first came about in this disease. It was a phase 3 randomized study that half of the patients got the sunitinib at a dose of 37.5 milligram daily. The patients used to get it daily, and they wanted to look at if the cancer took longer to grow. So what they found in that study was, as you can see here, it's just a graph. What you need to look at here is the experimental arm that is on the top is the winner, and they should not cross on top of each other. So that's what we want. So it's doing that, right? The sunitinib arm, which is the darker line, is on the top, and it's not crossing the other line, which is not doing any treatment. And technically, if you look at these numbers, there was about a 58% reduction in the chances of your cancer growing or you dying if you took the pill compared to not taking it. So definitely beneficial. The problem is sunitinib comes with a lot of baggage, right? It's a drug that has a lot of side effects, not easy to tolerate. Most common one we talk about to our patients is diarrhea, problems, which already a lot of patients have, but high blood pressure, something called hand-foot syndrome, where the skin of the hands and field can become red. And these are just basically off-targeted effects, which basically some other areas where have the same receptors, and we are unable to completely specifically target it to neuroendocrine tumor cells. So that's why it's not used as often in this in current day and age where we have such better therapies that are better tolerated. Infinitor, or Everolimus, as we call it, was again studied in pancreatic neuroendocrine tumors. As you can see here, half of the people got the drug, the other half didn't. Big study, 400 patients. And what they found, again, we want the nicer graph to be higher. So Everolimus is the purple line. It's higher up, which is good, and it's not crossing the lines. Both lines are not crossing each other, which is good too. In general, there's translated into a 66% reduction in the chances of your cancer growing or you dying from the disease if you took this drug compared to not taking it. Again, a very effective therapy. Everolimus is used routinely and very widely for this disease. Again, side effects are there, which come through this drug as we learn more and more. One of the biggest one is sores in the mouth. We've learned some way to monitor, measure, take care of them better with a steroid mouthwash. If your doctor is not prescribing it, make sure you tell them to prescribe it with the drug. A steroid mouthwash decreases the risk of those sores significantly. Also, it can cause your sugars to go up. So hyperglycemia is a big side effect of this treatment. And rarely it can cause inflammation in the lungs, diarrhea, blood pressure going up, the similar side effects, and tiredness. So and this drug you got to take every day. So these side effects are sort of long lasting. It's not that I'll have it for 2 weeks and then I'm free 2 weeks. It's sort of a long lasting side effect. Again, so they are targeted, but still they have some off target effects that cause problems. And we can ignore that. And then more recently, the chemotherapy, right? A lot of people who have pancreatic neuroendocrine tumors get chemotherapy with the drug called Cape-Tem. It's capecitabine and temozolomide. You're going to hear more about the details of the study later when they talk about the chemotherapy for these cancers. What I'm going to talk about is mostly that it did work, but that we are working towards targeting and personalizing the therapy for this disease too. So as an exploratory analysis of this big study done by Dr. Coons and her group, there they compared, half of the patients got temozolomide chemo alone, the other one got capecitabine and temozolomide. They looked at a marker. This is called MGMT. It's a special marker that they see in the tumor cells, which can be looked at in different ways. But what they found that if you were MGMT high, or if you had high expression of this specific protein, you tend not to respond well to chemotherapy. So, as you can see here, this is what I pointed out. If you were MGMT high, there's an 85% chance you're not going to respond to the treatment as well. So another way of, personalizing therapy, even though it's chemo, there's a way we try to do it. The most recent, drug that's come out is Belzutifan. Belzutifan is a drug that basically targets the HIF-2 alpha, which is a hypoxia-induced factor. So whenever there's decreased blood supply to the cancer cells, there's decreased oxygen level in there that leads to special chemicals being produced that lead to growth of the cancer. And that's one of the way these special cancers called the VHL-associated, which is von Hippel-Lindau-associated cancers grow, and pancreatic neuroendocrine tumors are part of that syndrome. That this drug, Belzutifan, is approved for any cancer that's associated with von Hippel-Lindau syndrome, but not for all pancreatic neuroendocrine tumors. And there's current studies ongoing to see if this drug is going to work for all patients with pancreatic neuroendocrine tumors. So it's a very targeted way of treating. In the patients where it worked, you can see here, 50% patients responded to the drug. So very rarely do we see shrinkages in this disease. Here in the VHL-associated cancer, there was actually responses that were seen. So another impressive drug that's coming down the pike that hopefully we'll be able to use. So when you come at non-pancreatic, so these were all the drugs we use for pancreatic neuroendocrine tumors. We talked about Everolimus, which is mTOR inhibitor. We talked about Sunitnip, which is a VEGF inhibitor. We talked about Belzutifan. And then we also talked about the somatostatin receptors. So these are all targeted agents that we were using all this while. For the non-pancreatic GI nets and other nets, unfortunately, there's not as many drugs as we would like there to be. The phase 3 randomized studies, that's the best studies we like to see, where we are making sure that the changes we are seeing or whatever we're observing is not by chance, where half of the people get the drug, the other half don't, and we follow them prospectively. There's only 2 studies, and the one that's positive, the one that's relevant, is just the Everolimus study, which is the RADIANT-4 trial. So we talked about Everolimus in the pancreatic neuroendocrine tumors, even for GI, so midgut tumors or intestinal tumors, lung tumors, any GI neuroendocrine tumors. This study was restricted to patients who did not have any carcinoid syndrome symptoms, so non-functional tumors. Clinically, there was a RADIANT-2 study. If we go to the history, there was another study which was not positive, which included the patients who had tumors that were having functional symptoms. But at this point, we use it for all patients typically who have GI or lung neuroendocrine tumors, which is a drug called Everolimus. Again, the study found that there was about the same very numbers as we saw. There was a 52% reduction in the chances of the cancer growing or the risk of death with the drug compared to not taking that drug. So again, a very effective therapy that's out there for our patients. The question is, how do we choose which one, right? So we talked about the side effects. There's some ongoing side effects. Another unique toxicity for these targeted therapy is cardiac toxicity. So heart toxicities are important things that we have to look for. And this is you cannot read it in detail. I tried to pull it up bigger. But in general, what it's saying is you see the central line. You see one line which is going vertically in that graph. That is basically the risk of cardiac issues if you weren't on any of these drugs, or it's similar to general population. So if you want, if where your drug lies is towards the left of it, that's good. If your drug lies towards the right of it, that's bad, okay? So when they looked at this curve, what they found was somatostatin analogs, so in lanreotide, somatulin, sandostatin, the curve, the big diamond, lied to the left of it, which means it's protective, which sort of is pointing towards what Dr. Muhammad just talked to you about. It probably prevents carcinoid heart disease. The second is Everolimus, mTOR inhibitors, and the third is Sunitnip or Sutent, or VEGF-targeted agents in general. And both these lie towards the right of the curve, more so for the Everolimus than the Sunitnip. And both of these drugs have some cardiac toxicities, can lead to, cardiac events, which otherwise you wouldn't see. So something that we have to keep in mind for our patients, because most doctors don't use it that often. We have to be attuned to the fact that we have to monitor cardiac health very closely with this disease due to the disease itself causing cardiac problems, and the treatments can cause that problems too. In general, how, we talked about the hormone control. I'm going to skip through that because I think we are anyways running short on time in general, just because of our issues. We talked about this tristat already. It decreases the hormone and it helps symptom control. We are wondering if it will have more benefits than just decreasing diarrhea. That's what it's been studied for. But since it reduces the hormone, could it improve? Could it lead to better cardiac health? Could it lead to more benefits in terms of all the bad effects that serotonin causes because it lowers the serotonin level? We don't know yet, but we'll find out. Unfortunately, for the poorly differentiated neuroendocrine carcinoma, these are the fast-dividing, high-grade cancers, a lot of symptom burden for these patients, there's not a whole lot of targeted therapies out there. There's literally just chemotherapy, as we do for any other cancers, just different kinds of it is what we do here. Now, how do we improve outcomes, right? We have to get better. We have all these things, but we need to do better to make sure we provide more personalized treatments for our patients, because not everyone is what they look like, right? So here you're seeing, your DNA test can tell you that the same tumor in 2 different patients can be completely different from what it looks from the outside. And that's why it's important that we, like for example, we published this in JNCCN, where we looked at the molecular profiling of a tumor for a patient with neuroendocrine, and they had this KIT mutation. It's just basically one genetic change, and there's a very active drug against that, and that patient was on that drug for 9 years after that. It's a drug which wouldn't be using in this disease otherwise. We had to fight with the insurance to get that drug approved for it. But these are the things we look for, right? That's how we want to personalize treatment. And here we want to make sure we emphasize what is the importance of next-gen sequencing to identify new targets. It's much more common in the poorly differentiated tumors and maybe pancreatic, not so much in the midgut GI neuroendocrine tumors. But again, we wouldn't know until we look. Right. So we did a pilot study comparing, whether there was any targets that we find in well-differentiated and poorly differentiated cancers. Once we got the results, all you need to see is the yellow points, which is the 2, are where we were targets that we could act on. All the gray ones were targets we couldn't act on. Important to know, there was very little targets that were seen in GI neuroendocrine tumors, very little targets that we could act on in the pancreatic neuroendocrine tumors, most of these concentrated in the poorly differentiated high-grade tumors. So even though we don't have a lot of target therapies for the poorly differentiated cancers, these tumors tend to harbor mutations, so on an individual N of 1 basis, we probably be able to find some more targets in them, which we otherwise cannot. We also look for RNA profiling, so just not look at the DNA, but also look at the RNA, look at the proteins in these cancers, and see if we find targets. So this is a good example of it. We did a small study where we looked at targets in patients, and we found that this target called EZH2 was much more expressed in high-grade neuroendocrine tumors than the low-grade neuroendocrine tumors, and much more higher in the poorly differentiated category. Just, these are the ways we are moving forward, right? These are paving ways for things that will come in future for these cancers, and we currently have a clinical trial based on these findings that we are just about to start addressing the specific epigenetic modifiers in neuroendocrine tumors. The other is immunotherapy, right? So immunotherapy was something that we thought would work for these cancers, doesn't work for the well-differentiated, at least the way and shape it is in right now. There is some data that in poorly differentiated cancers, there are some studies that have shown some benefit, but still pretty bad outcomes for this combination compared to what we expect with immunotherapy. The first study I did with immunotherapy was probably one of the first studies in poorly differentiated cancers. Out of the 40 patients we gave the drug to, only 1 patient had a response. And that probably was because they had some other underlying issue rather than the fact that they were neuroendocrine. So we need to do better, but that doesn't mean we're not doing it. There's a lot of things happening. These are targets, these are special treatments that are out there that people are working day in and day out to use and actually improve the outcomes and decrease side effects and toxicities of what we have right now. Yes. So these are some new drugs that are out there that are coming up. They must be in clinical trials right now. Cabozantinib. Surufatinib is a drug which actually showed benefit in phase 3 studies in both pancreatic and GI NETs. Unfortunately, the FDA didn't approve it because all the studies were done in Eastern Asia. So we are hoping that in future we'll get these studies and have more treatment options for our patients. There is a somatostatin receptor targeted chemotherapy, this PEN-221, which is being studied. There are viral vaccines. Then these are special kind of immunotherapy options, which is, again, targeting the somatostatin receptor. So the somatostatin receptor, I think, is the basis of how we're going to treat these cancers and keep developing our options based on that as we move forward and hopefully find options. So there are target therapies out there, actually work better than chemo in most of the disease except pancreatic NETs. The biggest challenge that we have in front of us right now, given the side effects versus not of these treatments, is how do we sequence them, right? How does a first patient, as soon as they come to me, and if they don't tolerate the somatostatin receptor analog or have progressed on it, what should I give them next? Do I do PRRT? Do I do Everolimus? Do I do CAPTEM? There is a lot of work that we are doing to learn the answers to the question. It's a very individualized decision right now, but I think with time we will absolutely get better at that, and there's novel drugs being developed. So thank you, everyone, for your time.